All right, so I guess we can go live right now. And good evening, everyone. My name's Yi, one of the committee for the ThursdayTen Road to Finals, run by the MedTech committee. And today we're going to be covering various topics that we are relating with endocrinology. Today, unfortunately, it's just myself as my other colleague Dee is unfortunately not available to present due to illness. So session may be running a bit slower as I'll have to multitask a bit, but hopefully I'm able to provide a good session as best as I can. Right, so I think I put an announcement on the chat to put the feedback form that our participants can fill in after this talk. And if you have any questions, you could just pop in the chat. And yeah, I'm just going to get everything set up and let's get started with this. Right, is everybody able to see the slides? Right, great. So, yeah, as I said, we just be focusing on 10 questions as through the usual Thursday 10 routine that we have. And we will get started with the first question. So, in this first question, a 65-year-old man is admitted to intensive care unit for sepsis secondary to a community-acquired pneumonia. He has had a past medical history of insulin-dependent type 2 diabetes and hypertension. While he was there over the past 48 hours, he has gradually become more brachycardic, fatigued, and intolerant to cold. Blood tests are performed with the results below for all of you guys to see. So, based on this information, what is the most likely underlying cause? If we can just put it in the chat from what we think, since we are there's not many people to put up a proper poll for this. All right, so that's a bit of time to try to dissect this information. So the answer to this question would be sick thyroid syndrome, and this question actually tries to aim to make everyone aware of the different types of hypothyroidism, underlying causes that could happen. As we all know, hypothyroidism is a deficiency of the thyroid hormone, and as such, you get a various range of symptoms from fatigue, weight gain, constipation, menorrhagia, arthralgia, and swinging of your mood as well, with intolerance to cold and a hoarse voice. Various examination findings you can get include a coarse face, a goiter, which you can also see in hyperthyroidism. So it's a general finding for any sort of thyroid pathology, dry skin, alopecia, and hyporeflexia. Basically, this means that if you think about it, hyper means you get all these symptoms that make someone active, while hypothyroidism makes someone appear sleepy and tired all the time, as I like to simplify in my head. And I guess you can see from the slide we have a multitude of different pathologies that can occur when we have a deficiency in the thyroid hormone. So, as we can see from the top, hypothyroidism classically can just present as itself and can be treated medically. Subclinical hypothyroidism is when I'm going to put another poll again just to make sure. All right, yeah, so we've got some answers for E for this question, which I can see where you guys are putting your ideas forward for this. You're technically on the right lines of thinking, but not technically the correct answer for this one. So the answer that I was looking for would be for small cell carcinoma of the lung, and I've put in a highlight over here that we have SIADH, Cushing's, Lambert-Eaton syndrome, which explains the proximal muscle weakness and is chemosensitive in treatment. Now, the reason why that, before I go into the reason why that would be the answer, is to explain what Cushing's syndrome is. It's a collection of conditions causing an excess secretion of the hormone cortisol, and it's much more common in females than males, classically. You have many different causes of Cushing's, and conveniently enough, which we have to painfully learn, they've come with different names that attach with Cushing's as well. So the most common cause that we have is that it can be due to excessive glucocorticoid consumption, such as using too much of a medication for asthma or for immunosuppression, which we call Cushing syndrome. So now that we have an idea that this may be caused by a tumor, unfortunately, Cushing's disease is the term that's only used specifically if there is a tumor in the pituitary gland, annoyingly for this. We can also have tumors in the adrenal gland, which we term adrenal Cushing's. And then for anything else that's outside of these hormonal sort of glands, we term it ectopic Cushing's. And the classic example that we usually refer to the most is small cell lung cancer. So Cushing's, with the excessive release of cortisol, causes someone to gain weight, have lots of mood swings, acne buildup, hirsutism, which is a male pattern baldness and growth of body hair. So it means that women suddenly can grow beards and will have baldness that classically seen in males. It would also affect libido in both males and females, and for females specifically, it can cause irregular menstrual cycles as well. So clinical signs can include the dorsal cervical fat pad, or classically termed as a buffalo hump before recently, and a plethoric face, which you can also see in older textbooks called a moon face. They also have a specific pattern of obesity where you mainly get it in the trunk and the upper limbs as well, as opposed to getting it all over the body as well. And a classic thing that I always like to refer is like purple striae, which are these purple superficial marks, which are a lot of like stretch marks that are dotted around the abdomen as well. And if it's specifically Cushing's disease because of a pituitary gland defect, you can get headaches and visual field defects as well. Generally, you can do your normal bedside investigations, your normal blood tests with a VBG, which classically shows a hypokalemic, hypochloremic metabolic alkalosis with a hyponatremia as well. Alongside this, you want to measure blood glucose for ruling out diabetes or ruling in diabetes in the stage, as well as various special tests, specifically a low-dose dexamethasone suppression test, which is basically administering a dose of dexamethasone and to measure the serum cortisol the following morning to see if there's a response. And if there is a failure to respond to that, influx of dexamethasone, you're going to basically confirm a Cushing syndrome with it. And the treatment usually is divided into managing the hypertension and glycemic control, and to stop the underlying cause. So if it's excessive glucocorticoids, you want to taper off the steroids. If it's a tumor like Cushing's disease or adrenal Cushing's, you might have to remove the tumor. And if it's ectopic adrenals, like we discussed earlier, you have to find the underlying primary cancer, such as this, where you have to go through some excessive surveillance and imaging to find a lung cancer, if any, as well as revisiting the history as well. Right, so that is quite a big whirlwind for Cushing's. Now we're going to visit another case, which is where we see a 52-year-old woman presenting to her GP with a progressive fatigue, weight loss, and dizziness on standing. The GP notes the below observations, which we can read over in the question. And on examination, the patient appears quite nauseous, has increased pigmentation of her skin, particularly around the palmar creases and the cheeks, buccal mucosa. And therefore, from all of this, the GP thinks that this could be an Addison's disease. But there are many causes of Addison's disease, and out of all these options, which one do you think is the least likely cause of Addison's disease? So I will give you guys a few minutes to think while I set up another poll. All right, so based on the answers I see over here, some of us have been going for A, and like the other one, it's another bit of a tricky question, but it's something that does appear in exams from time to time. So the answer would be a thymic hyperplasia, which is the odd one out of all of us, as increasing the size of your thymus is more associated with myasthenia gravis, which is a condition where you cause a generalized weakness due to acetylcholinesterase inhibiting. So what we're going to go through what Addison's disease is, which is where there is a deficiency in cortisol and aldosterone from the adrenal cortex being released. And there are many different causes of it. And we can split these causes into primary and secondary causes. Primary causes are due to a direct destruction of the adrenal cortex, and the most common cause of that in the UK is an autoimmune cause. Whereas elsewhere worldwide, we have a plethora of other causes, including tuberculosis, lymphoma, and hemorrhage, which we term as Waterhouse-Friderichsen syndrome. And this is caused by secondary to a meningitis leading to a meningococcal septicemia. Addison's disease can also be caused by secondary cause where we suddenly withdraw steroid medication, such as when someone goes into surgery and we do not taper the steroids acutely before they go into theatre. And being an autoimmune condition, most commonly in the UK, is associated with a lot of autoimmune related conditions such as type 1 diabetes, celiac disease, and sarcoidosis. Generally, the symptoms you have are very non-specific, but your examination findings do point you towards a diagnosis with the hyperpigmentation that we've seen in the history. You can also have vitiligo and the loss of pubic hair, in the axilla, and around the genital area. If you add all of that with signs of shock and the patient is comatose, you are dealing with an Addisonian crisis from that point. Again, investigations are trying to piece together to rule out other diagnoses, as well as to do a special test once you find these examination findings, which we term as a synactin test, which is where we give synthetic ACTH to try to drive the cortisol levels up, and we monitor them at 9 a.m. at 30 minutes and 60 minutes. If there is no response of the body to try to increase cortisol levels during that time, we will suspect Addison's disease from that point. So management generally, if we're dealing with a more stable patient, is to replace steroids as much as possible, prefer with hydrocortisone and fludrocortisone if the response isn't enough. And we're going to have to discuss with the patient on adjusting a hydrocortisone doses during intense illness or intense stress as well, and medical alert bracelets to tell everyone with information still requires if another attack occurs. If they are unstable, in the case of Addisonian crisis, we usually want to give hydrocortisone and fludrocortisone as quickly as possible with intravenous fluids to correct any hypovolemic shock, and as well as some glucose. So that is pretty much seeing a scenario between what happens when you get a lot of cortisol and a lot of or a deficiency in cortisol as well. This next question goes away from that topic, where we're dealing with a 45-year-old man presenting to the GP with excessive sweating, vision loss, and headaches over the past few years. He has prominent supraorbital ridges, prognathism, frontal bossing, and spate-like hands on examination. From reading all of this, thinking about the most likely diagnosis, what would be the most appropriate investigation diagnostically that you would like to order? Again, just making a poll for everyone right now. Right, we just give another 20 seconds before we move on. Alright, so what makes this question quite hard is that technically all of these answers are correct and do play a part in correctly investigating for acromegaly, which is the condition that this is describing. However, the question asks what is the most diagnostic, which means which of these investigations would point to be the most specific investigation for acromegaly. And that answer would actually be the oral glucose tolerance test. So the reason why that case is insulin growth factor is high in sensitivity but low in specificity, as it can also have a raised insulin growth factor 1 in many other conditions. Most commonly, you can see it in females for pregnancy. You can see it sometimes in hyperthyroidism. You can also see in obesity and rarely in carcinoid syndrome as well. Random growth hormone levels are no longer used anymore. This is a historical test that was used once upon a time. A magnetic resonance imaging of the pituitary gland, basically an MRI pituitary, is something that you should consider doing. However, it's worth to note that acromegaly is not only caused by a pituitary tumor, as we classically see in the textbooks. They can also be caused by masses in the adrenal glands called GHO mass, and GHO mass in the pancreas as well. Therefore, this is not the sole imaging that you will need to do to try to rule out causes of acromegaly. And the last choice of requesting photos from the patient over the past 5 years is helpful to have to support your history, but it's not a formal objective diagnostic test that we would like to use. So just to go over acromegaly really quickly again, it's a condition where you have a excessive release of growth hormone. So classically, jewelry, shoes, gloves would gradually get harder and harder to fit over time. You would have vision disturbances if you have a pituitary mass, weight gain, and excessive diaphoresis, which means a loss of sweating as well. You have a lot of back pain and hoarse voices alongside with this as well. And as you can see from this, a lot of examination findings with very niche specific medical terms that do come up in exams, and you may be asked to describe from time to time, which describes the appearance of someone with acromegaly. So a person with acromegaly would not only have your basic blood investigations, but as we noted down in the question, we can see that if the IGF-1 is raised, if your growth hormone levels are raised, and your oral glucose tolerance test is also abnormal, you're most likely thinking of acromegaly. You may also be doing some special tests and some special imaging to try to find out the underlying cause of acromegaly. And acromegaly is also the term that we use if it occurs in an adult, if it occurs in a child before the age of puberty, where there is no fusion of the epiphyseal plates yet, we term this as gigantism. So the management basically at this level at the moment is we're more focusing on a pituitary tumor, and that's where transfer nodal surgery is. If the tumor is located in the adrenal glands or pancreas, then you would probably aim to do abdominal surgery at that point. For those who fail to correct despite surgery or are not fit for surgery, we have to use medication. So some astaxanthin analogs like octreotide can be used to counteract growth hormone and inhibit it as much as possible, but they do come with lots of side effects as well. Radiotherapy, preferably the external beam form, can be used, but radiotherapy again also has its own side effects and may preferably be used as an adjuvant treatment rather as a full curative treatment. So that's kind of a word stop of acromegaly. We shall move on to the next theme of questions, where this time we see a 25-year-old woman present to the ED department after a fall from standing height. She unfortunately has broken her leg, and this has happened because she couldn't concentrate when having frontal headaches. She has no significant past medical history and is not on any regular medications. And on examination, you notice bilateral galactorrhea on breast expression. Visual field testing reveals a slight reduction in peripheral vision bilaterally, and her right leg shows no neurovascular compromise or tenting from the fracture site. As you can see over here, these are some investigation results that you're provided with, and some other specific tests that are done. So, based on all of this that has happened, and considering the imaging results, that's my little hint for this question, which would be the most appropriate first-line treatment for this condition? Right, just 10 seconds before I go ahead with the next bit of slides. And just seeing the answers right now, this topic always causes an even split in medical school, which I can remember from the last time. And there's always a bit of confusion between should you do a transfernodal surgery or should you do a bromocriptine. In this sort of situation, the answer is bromocriptine, and I'll talk a bit more about it and show specific examples in the next few slides about prolactinoma. But essentially, it's due to the size of the prolactinoma in the pituitary gland. Um, that makes you choose between transfernodal surgery or bromocriptine. Temozolomide is only used for aggressively growing pituitary tumors. External beam radiotherapy is only for big prolactinomas or very symptomatic prolactinomas such as bilateral hemianopia, and brachytherapy is not an approved treatment. So prolactinoma is basically a excessive release of prolactin, and when you have a patient that has these signs, whether they are male or female, of excessive prolactin release, it's important to know, is it a physiological release called hyperprolactinemia, or if it's something from a tumor such as prolactinomas. So the most common thing in women to try to rule out is if they are pregnant, which is why we do a beta HCG test all the time, and certain drugs that are dopamine antagonists, because dopamine inhibits prolactin, such as first generation antipsychotics, are very important to try to rule out. And as you can see, depending on the gender, the symptoms vary, but the common theme is that both will have some sort of form of galactorrhea and osteoporosis, which explains why this woman, in this case, despite being so young, manages to break her bones really easily. And to probably do your investigations for this, you, as I said, have to do a pregnancy test, a full range of bloods, including measuring the serum prolactin levels, and specific tests such as visual field testing to try to see if there's a bilateral hemianopia, or to try to see if there is a pituitary mass causing all of this. Now, as we were quite split in the answers, is either you go for surgery transfernodally or you manage it medically, and that depends on the size of the mass. If it's less than 1 centimeter, which in this case it is because it's 8 millimeters in length, then you want to go with medical management. And your first step is a dopamine agonist. You want to try to promote dopamine to try to inhibit as much prolactin as possible. In this case, you can use bromocriptine, but cabergoline is also another example as well. If it's more than 1 centimeter, you would want to try to do surgery, or if it's less than 1 centimeter but causes visual field compromise dangerously, that's another indication for surgery in a nutshell. Right, so this next question wants to cover a bit of anatomy. And a 34-year-old female who is 12 weeks pregnant with her first child, presenting with a medication-resistant hypertension and muscle cramps. Routine blood work shows up an electrolyte imbalance, and an ECG shows a U wave. She is noted to be low on renin in her blood tests. So, based on the diagnosis, which part of the adrenal gland is responsible for the hormonal changes as described in this patient? All right, so just looking at the poll, I think everyone has got the correct answer for this question, which is A, the zona glomerulosa of the adrenal cortex. Now, if anyone in the chat is able to describe what this condition could be, I'm going to give anyone any answer to see what we're talking about. No response, that's fine. So, in this case, we're talking about a endocrine condition called Conn syndrome. And Conn syndrome is basically described as a primary hyperaldosteronism, which means there is a sudden increase in the hormone aldosterone. As such, the role of aldosterone is used in the RAS system to increase sodium reabsorption and, as such, increase your blood pressure in the long term. However, as such, due to the pathways and the G-coupling proteins in your kidneys, this will lead to increased potassium and H plus excretion as well. And as such, you would get hypocalcemia, which is why you get the U waves and muscle cramps as seen in this patient. And due to the loss of your hydrogen, that's why you get metabolic alkalosis as a result. And just as a quick run through for anatomy, you can see you have your zona glomerulosa, zona fascicularis, your zona reticularis, and your zona medulla, and your adrenal medulla as well, which secrete various different types of hormones, which we've already talked about in this question. This next question is a bit more interesting, where we see a 37-year-old male about to be prepped for surgery for removal of tumors from the adrenal glands, and a month prior he attended his GP with palpitations, recurrent headaches, tremors, and feeling flushed. 24-hour urine collection tested positive for metanephrines, and his initial BP was 165 over 100, which is quite high. This was managed with propranolol, and he was intermittently managed for his symptoms from there. So, after successful resection of his tumor, he unfortunately went into cardiac arrest and is due to have an hypertensive emergency, which we have to manage right now. So, based on this scenario, what should have been done in his pre-op phase based on the answers below? So I will put another poll and we see what you guys think. All right, just so as we can see the poll over here, again, there's another sort of even split between B and E. In this case, the answer is B, an alpha blocker, and that is because we're dealing with a condition called pheochromocytoma. Now, pheochromocytoma, basically literally translated to a dark color cell tumor, is a tumor of the adrenal medulla, which we've seen in the previous question. This part of your adrenal gland is responsible for the secretion of adrenaline and noradrenaline. So why does this happen? Well, it can be familial, associated with men type 2 syndromes, can be associated with neurofibromatosis, and von Hippel-Lindau syndrome. And you have many different types of locations where your tumor can be present apart from your adrenal glands as well. The most common site outside of the adrenal gland being your organ of Zuckerndorf, basically just beside your bifurcation of the aorta and your abdomen. 10% of these tumors can be bilateral, so you can have it in both adrenal glands, which is a bit more of a nightmare. And 10% are malignant in nature, which means they have the potential to spread to lymph nodes and metastasize even more. Treatment is usually surgery, but the primary thing you need to do first, which is what's not done in this episode, is you need to control the blood pressure. You will need to provide a non-selective alpha blocker, such as phenoxybenzamine, before you give a beta blocker, such as bisoprolol. The general rule to always follow is that you always give an alpha blocker before a beta blocker. If you give a beta blocker first, you're going to have unopposed adrenal action, which therefore can tank the blood pressure in the long term, which is not great. And then once you use surgery to remove the tumor, then you pretty much just have to monitor the patient and make sure that they're stabilized and hemodynamically stable from that point onwards for the recovery. Again, this condition is quite rare, and I have actually never seen it before. So it's mainly something that you just need to know academically at the moment in time. In this scenario, we're dealing with a pregnant 30-year-old female who is just going through her first pregnancy at 28 weeks. She has polyuria and polydipsia, and she's otherwise fit and well. Which of the following are diagnostic criteria for her gestational diabetes? Just create a poll again for this bit. Alright, so just seeing the poll at the moment, we can see that everyone who voted for D, and that is indeed the correct answer in this case. And I think the reason that my colleagues has wanted to put this question inside is that in endocrinology, we tend to talk a lot about type 1 and type 2 diabetes. And even in obs and gynae, we don't really tend to focus on gestational diabetes a lot, which is why we wanted to highlight it in this scenario. So gestational diabetes has a lot of risk factors, including having a BMI of over 30, having a previous macrosomic baby, first degree relative of diabetes, having gestational diabetes yourself in previous pregnancies, and previous unexplained stillbirth. And there is a screening program that we do for all women to try to screen for gestational diabetes, which is quite similar to other conditions we've seen, which is the oral glucose tolerance test, like we've seen in acromegaly. So then you have your diagnostic criteria, which we've already seen, is that if your fasting glucose is above 5.6 and your 2-hour glucose is above 7.8, you're more likely to have gestational diabetes. And the easy way to remember this is just remembering 5, 6, 7, 8. So the first two numbers are for your fasting, your second two numbers are for your 2 hours blood glucose post. And as you can see over here, there is a plethora of diagnostic criteria and management for diabetes, gestational diabetes, which you can read in a bit more detail when you fill out the feedback form to get a copy of the slides. In this case, we have a 50-year-old woman who was recently diagnosed with depression and is started on citalopram initially. She, however, still complains of increased thirst and increased frequency of urination and constipation. She feels this is all related to her new antidepressant medications. We've done some blood tests which show the below results. And based on all these options, which one could best possibly explain what she's going through at the moment? Again, I'll just give a poll and take your time to answer this question. All right, so I can see from the choices why we are thinking about this. The blood test clearly shows as hypercalcemia, but the trick of the question is, what would the most likely cause of this hypercalcemia be? Fortunately for this question, the correct answer will be E, a parathyroid adenoma. Though guys are on the right track, you have to rule out myeloma and either parathyroid masses, but for myeloma, we don't really have enough information on to really diagnose that. You have to do a lot more investigations, such as blood films, serum electrophoresis, and kappa and lambda immunoglobulin ratios to really rule out myeloma, alongside a solid history to show hypercoagulability and increased vulnerability to infections, for example. So, why is it a parathyroid adenoma? As you can see from this, we have the classic symptoms of hypocalcemia, stones, bones, and groans, and that is why from the history, without doing the examination, we can see that it's a hypercalcemia, and that's usually regulated by your parathyroid hormone, which is produced in your parathyroid gland, as you can see over here. And one of the most common causes of hyperparathyroidism is a primary hyperparathyroidism, which is where you can see from this example, your calcium is high, your phosphate is low, and your PTH is also normal. So very straightforward, very obvious pattern of hypocalcemia or hyperparathyroidism. 80% of these are actually not even picked up. So this woman is in the not so lucky 20%, where she actually presents with symptoms as well. And the most common cause of primary hyperparathyroidism will be a parathyroid adenoma, which is responsible for a vast majority of these as well, which is why this question is asking for the most likely, but everyone here is not wrong in saying that we should not rule out everything else. Apart from this, you sometimes can find X-ray findings of hyperthyroidism, which can be described as a pepper pot skull or raindrop skull in some textbook, which is where you get little spots in the skull, which you can see in the next slide later, and a finding called osteitis fibrosa cystica. Most of this treatment is definitively, which is where you have to stop the parathyroid hormone from being released, which is why you do a parathyroidectomy. You're going to have to treat it conservatively as well with medication as well to try to reduce your calcium. And these X-rays are just good examples of what I was describing on your X-ray findings with your pepper pot skull and your echo osteomyelitis of your terminal phalanges over here. And now we're moving on to the final question of this lecture, which is where we see a 45-year-old female with bipolar disorder attending an endocrinologist appointment after suffering from polydipsia and polyuria for the past month. She undergoes some urine osmolality testing as such, and a water deprivation test as well. And she goes through a DVAP trial as well to help with her symptoms. Unfortunately, based on all of this, she continues to be symptomatic. So based on what could be the most likely cause and what could be the most likely investigation results, um, just pick the most suitable option out of these 5 options. And I'll just create the very last poll of this lecture. All right, just for the sake of time, to try to leave a little bit of time for questioning and to wrap up the lecture, the answer for this question would be for C, which is a nephrogenic diabetes insipidus, where you get a low urine osmolality and a low urine osmolality still after a DVAP. So diabetes insipidus is a condition where you have a an excessive deprivation in ADH secretion as well. And you have 2 different types of diabetes insipidus. You have cranial diabetes insipidus, which is due to inadequate ADH production from your pituitary gland, from your hypothalamus before secreting the pituitary gland. And then you have nephrogenic diabetes insipidus, where you have an inadequate renal response due to a resistance in responding to the antidiuretic hormone that's being released. In this sort of case, where the female patient with bipolar disorder is being managed, a common medication that's used to manage bipolar disorder is lithium, and that is a classic example and the most common example of nephrogenic diabetes insipidus. And as such, we can see that it depends on the pattern of your water deprivation test, which is quite dangerous to do, as it involves ensuring that there is more than 3 liters of water being produced by the patient. So you have to monitor the fluid hydration quite regularly, and you have to do a synthetic desmopressin inside, which is a synthetic ADH sort of analog, to see if there is a response to increase the ADH in the body. If you're dealing with a nephrogenic diabetes, such as in this case, you'll want to firstly give some desmopressin first, as well as some thiazide NSAIDs to try to correct everything else. And all this information can be looked into a bit more closely in the slides over here once you fill in the feedback form. So we just have 8 minutes left to spare for this lecture, and thank you so much for everyone who's participated and attended today. Here is our form to our main website, and to see if you have any more questions before I wrap up the lecture. And I just wanted to double check from everyone else who is in the chat to see if you got the link to our feedback form for us to fill out, as we appreciate a lot of feedback for us to improve our coming lectures in the future. So I'm just going to take everyone back to the first slides to see if we can get the research thing. There we go. Announcements. I'll try to put in the chat. I'm just going to turn it off live. Yeah, for some reason my chat function is not working today, so I'm just going to start a poll to try to see if anyone can copy the link instead and fill it out from their browser. Hopefully that should be sent. I just apologize that it can be a bit more convenient as my chat function is not working at the moment. And thanks a lot, Paul. I really appreciate that session. Yeah, these are specifically challenging SBAs as they try to pull in some content that are not normally managed and assessed in exams classically, but it's good to try to wrap up some knowledge and some topics and bits of knowledge for each of these conditions that may be missed out from time to time. Right, I'll still be here for the next 5 minutes to answer any last minute questions or to go over anything that we covered in the slides. And thank you for attending today.